My name is Alessandro Vannucchi. I'm from the University of Florence, the hematology department, and I am the responsible of the Center for Research and Innovation of Myeloproliferative neoplasms in Florence. Today, I'd like to discuss about one topic and then the second one, but both refer to the issue of how can chromosomal and mutational abnormalities in chronic MPNs help in clinical decision-making, and especially how can they help in selecting patients at high risk of disease, and therefore to identify the best suitable patient for stem cell transplantation. The last years have clearly witnessed a tremendous advancement in the understanding of molecular pathogenesis of chronic MPNs. And this started in 2005 with the identification of the JAK2 V617F mutation, followed by mutation in JAK2 exon 12 and mutations in MPL. Then we had to wait until 2013 when mutations in calreticulin were discovered. And so now we have three driver mutated genes, JAK2, MPL, and calreticulin, that are main diagnostic criteria. Also in the just recently released novel classification from the WHO and the International Consensus Conference. It is the later one recommends to use this mutational search in any patient suspected to have an MPN. It also suggests that we should go with sensitive tests because experience is now pointing to the fact that some patients may have a very low JAK2 mutant allele burden. That means the proportion of mutant allele over the wild type one. And it is also important to distinguish the two variants of calreticulin, type 1 and type 2, because they have not only diagnostic relevant, but also prognostic relevant. And when we have done these three mutations, we have about 15% of patients with ET and more or less the same with primary myelofibrosis who are considered negative for the three mutations and therefore are defined as triple negative patients. These in terms of diagnosis may make things more complicated, and it is suggested to go to search for other uncommon somatic variants in JAK2 and MPL, as well to exclude rare germline variants that might be associated with hereditary forms of thrombocytosis of erythrocytosis that mimic MPN. But it is also important to have in mind that triple negativity in patients with ET and PMF also has prognostic relevance. And in addition to these three driver mutations and eventually the triple negativity, more recent data have pointed to the fact that patients with MPNs have several other mutated genes that are not specific for MPNs. They are present in myelodysplastic syndromes, in other more rare MPNs, as well as in acute leukemias, and these are globally called myeloid neoplasm-associated gene mutations. The presence of these mutations is in part of the patients, so they are reached in patients with primary myelofibrosis, and they can be very important in establishing the prognostic characteristics of this disease. And on the top of mutations, we have basic data coming from years of study that show that there are also selected cytogenetic aberrations, particularly in patients with myelofibrosis, who might have indeed different chromosomal involvement that can be listed in different risk categories. And according to the most updated of these categories, they might help to distinguish patients in low risk or favorable risk category, unfavorable and very high risk category. So now we are in the position that we have a quite clean, I would say, maybe not complete, of course, but a very clean picture of how cytogenetic aberrations and mutational abnormalities, driver genes, and other non-driver genes mutated, that is very useful and is recommended to be employed for making diagnosis of MPNs, and also start to classify the patients according to their risk. So now I'd like to go in more depth on how we can use this molecular information for risk stratifying patients, particularly patients with myelofibrosis. We know that mutations are enriched in patients with myelofibrosis. These patients also have the less favorable outcome among the MPNs. And so it is very important to have in our hands tools that allow us to identify the predicted worst patient, and this patient should be referred at the right time to the procedure of stem cell transplantation that remains the only curative option. So the currently most used scoring systems are those that derive from studies that use a number of hematological and clinical variables, and I mean the IPSS, the DIPSS, and the DIPSS plus. But now we have more recent score, in particular the MIP70 and the MIP70 version 2, that are integrated genetic and clinical scores. These scores include most of the previously identified variables, clinical and hematological, associated with survival, in particular anemia that can now be categorized according to the level, to the degree of anemia, the leukocytosis, thrombocytopenia, presence of blasts in the peripheral blood, the presence of constitutional symptoms, and in terms of molecular variables, the absence of carreticulin type 1 mutation that has been shown to be favorable in terms of prognosis in patients with primary myelofibrosis, presence of mutations in any one of a small set of genes that are called high molecular risk category, and this includes any mutation in AZXL1, EZH2, SRSF2, IDH1, IDH2, and any one mutation just configures this category of a high molecular risk. But also the fact of having 2 or more HMR mutated genes has prognostic value. And finally, the MIPS score also includes the presence of an unfavorable karyotype and a very high risk karyotype. So if you use these variables according to the scores, and there are also website where you can calculate the score of the patient when you have the patient in front of you in your office, then you can select patients in different categories that are 3 categories for the MIP70 and 5 categories for the MIP70 version 2. This one includes in particular a very high risk category where less than 5% of the patients are alive at 5 years. There are other scores, such as the GIP score that is based only on genetic variables, and another score that has been developed by English College that is called the Cambridge score, that are less used in clinical practice because they require a consistent number of information. So we can now say that the most integrated score is the MIP70. This is included also in the NCC and guidelines, and it helps to select patients for stem cell transplantation. And at this regard, we also have to mention that the group of Nicholas Kroger developed a further molecular integrated score that addresses the risk of being transplanted for patients with myelofibrosis. These scores include the clinical variables related to the patients, such as age and the Karnofsky score, variables that are associated with the donor, such as the HLA mismatch, and of course, hematological variables such as leukocytosis and thrombocytopenia, but it also includes the presence of AZXL1 mutation and a non-carreticulin MPL mutated genotype. And this score allows to identify 4 different risk categories where expected survival after stem cell transplantation ranges from 90% at 5 years for low risk category to 34% at 5 years for very high risk category. So just to summarize, now in patients with primary myelofibrosis, we have the availability of scores that have been definitely improved over the classical scores of the IPSS family, and that by including novel molecular variables, allow to better stratify patients in categories that are largely IPSS and DIPSS independent, therefore allow to re-stratify patients, especially those of the intermediate risk category. The situation is still some kind of ongoing work for patients with secondary forms of myelofibrosis post-PV and post-ET. There is a novel score that is called the MySEQ-PM score that includes 1 molecular variable, and this is the presence of a calreticulin unmutated genotype. This score is, I mentioned, work ongoing because we are now trying to see under the leadership of Francesco Passamonti to incorporate other mutations and ask ourselves if they can help in better stratifying this category of patients. So I hope to have helped you to move through this complex field of changing risk scores for patients with myelofibrosis. The aim is to be better and better in selecting right now the right candidates for stem cell transplantation. But the hope is that with the availability of novel drugs, these scores might also help in selecting one drug compared to another one. Thank you for your attention.